Our discussion will also address the newest FDA treatments, lecanemab and donanemab. We will wrap up with an opportunity to take questions from the audience. And by the end of today's session, I hope you'll leave with a deeper understanding and an appreciation of both the current landscape and the promising possibilities for Alzheimer's diagnosis, treatment, and care in Hawaii. We have two speakers today that's joining us, and our first speaker today will be Dr. Abraham Chung, followed by Dr. Kuwaiti Shu. Dr. Chung is a neurologist with a strong academic and clinical background in both epilepsy and Alzheimer's disease. He earned his bachelor's degree in biology from Harvard and an MD and PhD in neuroscience from the University of Pennsylvania. He completed clinical training at UCSF. His research has focused on Alzheimer's disease, specifically beta amyloid processing and plaque formation. At Scripps Health in San Diego, he established the epilepsy monitoring unit and implemented continuous EEG in the ICU. He also collaborated with San Diego's Alzheimer's Project to develop guidelines for diagnosing Alzheimer's. Now at the Queens Medical Center, he aims to improve dementia care in Hawaii. Dr. Kuwaiti Shu is a neurologist and educator with a strong background in clinical neurology and research. He earned his MD and PhD in biological chemistry from UCLA and completed his neurology residency and behavioral neurology fellowship at UCSF. He also completed a postdoctorate research fellowship in biochemistry. Currently, he is an assistant clinical professor at Jabsum, where he teaches neurology. Dr. Shu also holds leadership role as the department chief of medical subspecialties at HPH and vice chair of the board of managers at Hawaii Health Partners, while serving as a staff neurologist at Palimomi Medical Center. We'll begin with Dr. Abraham Chung. Thank you.
Okay, great. Thank you so much for that introduction. And I'd like to start by asking a quick question. How many people in the audience are primary care doctors? Awesome. This lecture that I'm going to be doing right now is really meant for you. So I appreciate everything that you're doing, and let's get going with the talk. So I don't have any financial disclosures, but I will make it clear that the things that I'm going to be talking about today has to do with the work that I did with the Alzheimer's Project of San Diego County, where the San Diego area recognized that there's a growing problem with lots of people having concerns about memory impairment, many people being diagnosed with dementia and Alzheimer's disease. And so we came up with practical guidelines that primary care doctors can use to screen, diagnose, evaluate Alzheimer's disease. And the second part of this is, well, that concept got picked up by peer review, and so the guidelines that we created were taken to different annual meetings for primary care organizations, and we did grand rounds across the country to spread this concept. And those concepts are what I'm bringing to you here today. So locally, if you go to the website for the Alzheimer's Association, the Hawaii chapter, you'll be greeted with this latest accomplishment of the Silver Alert being signed into law. And I don't have time to go into the details of that, but if you're curious about what that is, please be sure to ask about it at the question and answer session at the end of this portion. But at the website, what you'll see is the staggering statistic of nearly 100,000 kupuna and others in Hawaii being impacted by Alzheimer's disease or other forms of dementia. That is a staggering number. And indeed, whoops, I hit some button.
Sorry. Do we have tech in the room?
Let me see if I can.
Maybe if I hit this. 1 second.
Thank you. Thank you so much. If you look at the statistics as of 2020, for people aged 65 years old and older, there were more than 30,000 people that were diagnosed with Alzheimer's disease. And what that means is that in that age group, more than 10% of the people have that diagnosis. That is a huge statistic. And this problem was recognized long before, and this was before my time, but back in November of 2014, then Director of Health penned this open letter to the medical community saying that the number of people in Hawaii who have Alzheimer's disease is likely underrepresented because of lack of early detection, diagnosis, and underreporting. So even back then, the Department of Health was strongly urging the healthcare personnel to consider the importance of early detection, diagnosis of cognitive impairment, and dementia. This concept of the need for early diagnosis became really important as of late because the FDA has approved disease-modifying therapy, lecanemab and donanemab, which will be discussed in more detail later on in this session. Lecanemab was approved a year ago. Donanemab was just approved recently. These are treatments for Alzheimer's disease. And there are some limitations in terms of what these medicines can do for people. But there's a couple of points on this slide that I really want you to recognize. One is that this treatment is only for people who have Alzheimer's disease. Even if somebody has dementia, if the underlying diagnosis is not Alzheimer's disease, they're not candidates for treatment. Additionally, only patients in the early stage of the disease are eligible for the treatment. And so if the diagnosis is made later when the patient has reached moderate stage or advanced stage, they're no longer eligible for the treatment. And so this really raises the concern for this conversation that you do not want to have with your patients. So if I had been told about the new treatment option in time, I would have asked for it. But now it is too late for me. So even though this treatment is not going to be really good for everyone, and even those people who are eligible may choose not to proceed with the treatment for their own personal reasons. But we want to make that decision something that the patient and their families will make, not one that's made for them because the diagnosis is made too late. So the question is pretty clear. We need to diagnose Alzheimer's disease and we need to diagnose it early. But what's the solution? And that's been the hard part. There's really no easy answer because primary care doctors, if they send people with memory concerns to neurologists, there's only so many neurologists around. We get inundated, the appointments get backed up. We can't possibly see everyone that has concerns for memory impairment. And if we ask the primary care doctors to do more in terms of diagnosing Alzheimer's disease, well, they don't really have a lot of time. They're dealing with a lot of medical conditions in a limited clinic appointment time. Adding on the responsibility of recognizing and diagnosing Alzheimer's disease just gets to be too much. And so this has been going back and forth between primary care doctors and specialists for quite some time. So to try to incentivize primary care doctors to do a bit more, Medicare has offered this new CPT code as of 2017, 99483. It can be used every 180 days, so twice a year. It is used only for evaluating and monitoring people who have memory impairment that may lead to the diagnosis of either dementia or mild cognitive impairment, or it may turn out to be some other issue that is causing the memory concern, such as depression or anxiety. But if someone is raising concerns about memory and you are taking the time to evaluate that problem, you will be rewarded with this CPT code because the reimbursement rate is higher. But to take advantage of the CPT code, there are some documentation requirements. There are 10 things that need to go into the note for the day that you use this code. A number of these can be time-consuming, like a validated tool for memory assessments, such as MoCA or SLUMS, functional assessment of the patient, formal staging of the dementia, the neuropsychiatric behavioral symptoms evaluation. All of these things do take time. And so just recognize that if you do take advantage of this, the reimbursement rate is higher. And this is the information that was published by the American Academy of Neurology. If you look at the codes for level 3, level 4, and level 5 outpatient follow-up visits as of 2022 and 2023, the more complicated the situation, higher the RVU. But if you use that CPT code 99483, the RVU rate is even higher. So if you can take advantage of this, certainly it'll be worth your while. And if you will take advantage of it and you collect information about the patient's memory impairment, well, how do you reach a diagnosis? And that's where the work from the Alzheimer's Project of San Diego comes in handy. This is a guideline for screening and diagnosing Alzheimer's disease that we make available to anyone who is interested. And in fact, the organizers have the full PDF file of these guidelines, and they can be made available to you. But if you do go through the guidelines, oh, actually, there is the code that you can use to download the PDF file for yourself to your own personal device. Feel free to download as much as you want and spread it around to anyone who might be interested. This is available free to the medical community, anybody that wants to pursue it. And in it, you will find a couple of algorithms. One is for screening, when you first recognize that a patient has some memory difficulty. And the second algorithm is actually for the evaluation. So it's a deeper dive to try to figure out exactly what the underlying problem may be. So I'm going to go through these for the rest of this session. So for the screening visit, you may recognize that there's a problem by asking some simple questions, such as, are you noticing a problem with your memory? Or do family members or friends notice a change in your memory? Or do you think that your memory has changed over the past couple of years? Or are there particular activities or tasks that you're now having trouble completing? And so this information may come from the patient during the visit, or if there's a companion who is arriving with the patient, they may be the one that points out that there's a memory problem. But if you do realize that there is a memory concern, the screening starts with doing a memory test. And so for this phase of the assessment, we recommend that you use the easiest, quickest mini-cog testing. Score of 3 or less is a failing score. It just takes a couple of minutes to do. It's pretty quick. You can also have the informant complete a questionnaire, the AD8, which can give you clues about there being memory impairment. And you should assess their functional status. And just by going through this, if everything comes back normal, you have the opportunity to reassure the patient and family that as of that day, there's no obvious problem that has been detected. And so the simple table here explains how you come to the different diagnoses using this screening and evaluation algorithm. You look at how they do in terms of cognitive function from the cognitive test, and how they're doing in terms of their function. If the test score is normal and they're functioning fine, but they're complaining about memory impairment, that is what we refer to as age-related cognitive decline. And so there's really not a big concern for that population. But if the memory test yields an abnormal score, but they're still functioning fine, that's what we call mild cognitive impairment. And when the memory score is abnormal and their memory impairment is significant enough that they're functionally impaired, then we're delving into the diagnosis of dementia. So pursuing the screening algorithm further, if the screening assessment yields abnormal findings, either through the memory test or through the informant from the person accompanying the patient, first thing that you should do is look for reversible factors. Is there depression, hearing loss, some other causes of cognitive impairment? Whatever you find, first take care of that, because the memory problem may resolve. You may consider doing some simple screening laboratory tests for thyroid function, vitamin B12, or any others that you find appropriate for that particular case. If you find an abnormality, treating those things may resolve the memory problem. If you treat identified reversible factors, but there's still no improvement in terms of their memory function, you should consider the possibility of non-dementia or Alzheimer's disease mechanism for memory loss, which is psychiatric issues like depression, anxiety, and whatnot. Hopefully you will pick up on those signs from just talking with the patient or maybe going through some of the tools like PHQ-9. If there is concern for a mood issue, the referral should go to a behavioral specialist such as psychiatry or psychology. If those factors are not present, then you should proceed with the actual evaluation for dementia. If you find red flags, if the memory problem is rapidly progressing in a matter of the 6 months time frame leading up to your assessment of the patient, or if there's a recent sudden change in their cognitive status, or if the memory problem is happening in someone who's younger than 65 years of age, those are red flags that might prompt you to seek neurology consultation sooner. If those red flags are not present, then you would proceed on with the evaluation in the primary care clinic, and that involves collecting a good history, getting a more detailed information, doing function analysis, looking for signs of behavioral changes. And with regard to the cognitive assessment, there are a number of validated tools that are available, but just recognize that with the mini mental state examination, the licensing for that tool is owned by a particular business, and they are expecting you to purchase those tools from them. And if you have your own copy and you're making Xerox copies of the mini mental status examination, technically you're supposed to be paying them a royalty. And so some people may be just getting away with it under the radar, but just understand that if you are using mini mental state examination without paying that company royalty, you could be setting yourself up for liability issues. Just be careful about that. We favor MoCA testing. MoCA does have an option to get credentialed by the copyright owners. It's a new option that they're offering for a fee. But in terms of clinical use for a clinical setting, you are free to use MoCA testing at will. So you can make just copies of it or download it from their website. Do what you like. And for depression screening, there's a lot of different tools available. I think what I've seen most since I arrived here in Hawaii is the PHQ-9. If the mental status examination is normal, or if it's just borderline abnormal, and you're seeing signs that there is a mood issue, such as depression, do not underestimate the effect that mood disorders can have on cognitive functioning. Please seek evaluation from a psychiatrist and see what they can do. If that is not present and you are seeing abnormal findings from your evaluation, then you can dig deeper to see what the underlying problem may be, maybe a more comprehensive laboratory assessment. You can consider getting a brain imaging. You can also consider doing neuropsychological testing as well. Just recognize that if you order neuropsychological evaluation for everyone that complains about memory loss, then the neuropsychologist will be overwhelmed and this whole system is going to fall apart. So be judicious. If there's no significant problems, just follow these guidelines. If there's a serious problem that is pretty obviously dementia, you probably don't need to order neuropsychological evaluation. For those borderline cases where you're thinking that maybe it's mild cognitive impairment due to Alzheimer's disease, or maybe it's depression, but it's not certain, those would be ideal cases where you should get help from a neuropsychologist. And going through this process, the patients that you're evaluating will fall into one of three categories. One is that they have dementia, but they have some red flags that are atypical cases, and they're not the usual Alzheimer's disease because they have Parkinsonian features, maybe hallucinations, there's prominent aphasia, there's early onset, rapid progression, fluctuating symptoms, unexplained visual impairment, there may be severe depression. If there are those atypical features, refer those patients on to the appropriate specialist. It may be a neurologist to diagnose the atypical non-Alzheimer's dementia, or they may go to a psychiatrist to diagnose mood disorders. And if you have access to a geriatric specialist, they can be very helpful too. They understand these concepts very well. Beyond those, the patients most likely have some form of Alzheimer's disease, and if they are in the moderate to advanced stage dementia, then those cases are not really eligible for the new disease-modifying therapy. The only patients that fall into either mild cognitive impairment or early stage dementia due to Alzheimer's disease, that category of patients, they're the ones that you are looking for. And if you find those patients, please do send them on to the appropriate specialist, as they are candidates for the treatment. And we can have a good detailed conversations with them about what the pros and cons are for receiving either lecanemab or donanemab, and we'll make sure that they get the right treatment if they want it. I'll just take a moment to explain how we are approaching this problem at Queens. And if you like to utilize this type of an approach wherever you practice, you're more than welcome to do so. Traditionally, if somebody has a memory concern, the primary doctors would refer them on to either neurology or geriatrics. Our specialty clinics would get overwhelmed with consultation requests. Sometimes they end up in inappropriate clinics, either due to not being eligible for lecanemab or donanemab, or because there's such advanced cases or whatnot. And so the new approach that we're instituting now is for members of the QCIPN group. That's Queens Coordinated, I'm sorry, that's the Integrated Physician Network, thank you. I'm still getting used to all these acronyms. We have licensed social workers that support our network. And so as a primary care doctor who are members of QCIPN, if you identify someone who has a memory impairment, you can start by putting in a referral to QCIPN. And then the social workers will meet up with the patient and do the memory testing and function analysis and assess for any neuropsychiatric issues and whatnot. And they will send that information back to the primary care doctor. Then the primary care doctor is in a better position at that point to make a decision as to what to do. If things are still uncertain, they have the option to send the patient back to the licensed social worker for reassessment, presumably once every 180 days, because you can take advantage of that CPT code 180 days. And you'll monitor the patient that way until you come to a decision about there being a significant memory impairment. And if that is a early stage issue where the patient is a candidate for the disease-modifying therapy, the referral will go to neurology, and we'll make sure that they get the treatment if they want it. If the dementia due to Alzheimer's disease is more advanced, and they're really not a candidate for that type of treatment, those patients would go to geriatrics, and geriatrics, as experts in dementia care, will continue the medical management of their dementia. And this is how we're trying to streamline and make it more efficient in terms of making sure that the patients get their evaluation early with the help of the social workers, and clearly delineating which specialties the patient should be referred to. So that's the conclusion of my talk. Thank you very much for your attention. And once again, here's the code to download the guideline if you'd like to get a copy for yourself. Thank you very much.
Thank you, Dr. Chung. And now I'll turn things over to Dr. Huwei Shu.
Hi, everyone. Thank you for coming and for your interest in this very important topic. This is very near and dear to my heart, having a father who died of Alzheimer's disease. And so, I'm very happy to share with you some very interesting and I think likely to be very impactful developments in the diagnosis and treatment of Alzheimer's disease, the biomarkers and the new treatments that Dr. Chung already spoke about. And so let's move on. I have no disclosures. Today, we're gonna go over biomarker tests for Alzheimer's disease, MRI imaging, amyloid PET imaging, CSF analysis, and the up-and-coming blood testing. There's a role for all of these different types of tests in the diagnosis, and we'll try to talk about some of the nuances of that. And then we'll in the second half of the talk, we'll talk about the new anti-amyloid monoclonal antibodies, lecanemab and donanemab, which again, I personally am just thrilled by the development of these new treatments, and I hope you can see where the excitement comes from. Before we go into this, though, I'd like to review for you, I think, the scientific basis of where many of these tests come from and where the treatments come from, and that is the amyloid hypothesis of Alzheimer's disease, right? Alzheimer's disease was defined originally pathologically, 150 years ago, due to the discovery of amyloid plaques, seen here on the left side of the screen, and neurofibrillary tangles, seen here on the right side of the screen, pathologic markers of Alzheimer's disease in autopsied patients, just 2 or 3 patients, I think, in the initial studies. And 100 years of research into these findings basically has led, I think, the field to a general consensus. Again, there is always some disagreement, but general consensus into the following pathway of how this all seems to work, right? That there are genetic factors as well as environmental factors that lead to Alzheimer's disease through this pathway, most notably trisomy 21 or Down syndrome, presenilin mutations or APP mutations that cause early onset Alzheimer's disease, and ApoE4 alleles or variants that increase one's risk of developing Alzheimer's disease. The idea is that these genetic factors lead to a predisposition in one's body and brain for A-beta or beta amyloid aggregation, okay? So what does that mean? That means they stick together more than normal, okay? And what that leads to is soluble A-beta oligomers, so small numbers of these molecules sticking together and floating around in the spinal fluid around the brain. But it also leads to A-beta plaques, which are larger aggregates of beta amyloid that deposit into the brain tissue itself, as seen in the amyloid plaque, right? That these two forms are in dynamic equilibrium, right? And so there's beta amyloid that's soluble, floating around your brain, that deposits into these plaques, and it can flow out of the plaques and back into a soluble form. And there's a constant kind of low-level flow between these two states, okay? And then there's something about the beta amyloid that, again, there's a lot of research into this, that leads to synaptic dysfunction. So what does that mean? That means, that the circuitry of the brain with the neurons connecting to each other and communicating with each other, that the circuitry is disrupted and not functioning at the highest level, right? And at the same time, we also see neuroinflammation, and that's typically white blood cells and sometimes antibodies in the spinal fluid and in the brain that seems to correlate with this process kind of as Alzheimer's disease develops. And these factors then lead to eventually the formation of these neurofibrillary tangles, which are aggregates of another protein called tau protein within the neurons themselves. And so the idea then is that the amyloid aggregation leads to these processes that then lead to the development of these neurofibrillary tangles. And so there's an order of events in the development of Alzheimer's disease, okay? And that all of these factors then somehow lead to widespread neuronal dysfunction, so the brain malfunctioning, and eventually death, so the death of the brain cells themselves. And as that progresses, then patients develop dementia, and in their brains, you can see the plaques and the tangles and the neuroinflammation. Okay? So this is the general framework by which I just want to make sure everybody has an idea about. We'll refer to this throughout the rest of the talk. So the first biomarker we're going to talk about is the most basic. It's the oldest, developed in the 1980s, brain magnetic resonance imaging. And I would argue that it's still the most important general test for evaluating pretty much all brain conditions. In Alzheimer's disease, we see brain atrophy on these MRI scans. And there are different patterns of brain atrophy that are typically seen in Alzheimer's disease compared to other conditions, including other forms of dementia. In Alzheimer's disease, usually you see atrophy in the parietal lobes and in the hippocampi, which we'll show you in a second. But it's also very important, again, for ruling out some of these other conditions like strokes, tumors, bleeding, brain swelling, edema, all of these things. I want to make clear here that brain magnetic resonance imaging does not detect A beta protein, plaques, or tau protein tangles. What we're seeing here is the late stage of Alzheimer's disease where the brain cells are starting to die and the brain is getting smaller, okay? And so how does this look? So hippocampal atrophy, the hippocampus is, there's two of them in your brain, and each one is involved in a short-term memory formation. And the area of the hippocampus on this coronal section of the brain is here. There's one on this is actually the left side when we look at these MRI scans, and there's one on the right side. And in someone with Alzheimer's disease, you will see that the volume of that structure is typically significantly smaller than in a normal elderly individual, right? This is pretty subtle, honestly. I would say most people who look at these MRI scans don't pay a lot of attention to this. There are automated, computerized, artificial intelligence, automated ways to tell this these days, and many MRI scanning facilities will utilize these to give you advice. But as a neurologist, old school, I still look at this myself and look very carefully at these areas personally. Right? Parietal lobe atrophy. What does that look like? Well, in this patient, this is a patient of mine from several years ago, and this is an axial kind of slice of her brain. Lower down, kind of towards the lower part of the frontal lobes, the occipital lobes here, and you can see, you know, there might be a little bit of atrophy, but it's pretty uniform throughout the brain. But towards the higher parts of the brain, you can see there's a lot of atrophy, particularly in the posterior part of the brain here, which are the parietal lobes. This patient, eventually we diagnosed her with early onset Alzheimer's disease in her 50s, and unfortunately she has passed away. Okay. This is more subtle, but patients with Alzheimer's disease often overlap with patients who have cerebral amyloid angiopathy. And these are findings that that correlate with microhemorrhages in the brain. So these little black dots on particular types of MRI sequences. This is called a SWAN sequence. Some people, it's similar to what might be called a gradient echo sequence, or there's different names for this. But basically what this shows is small areas of hemorrhage where very, very microscopic blood vessels have burst, but not caused a massive hemorrhage. And in this case, there are hundreds of these microhemorrhages in this person's brain, as you can see. Actually, let me see. Yeah, this patient did not have a diagnosis of Alzheimer's disease at the time of this MRI scan, but again, people with Alzheimer's disease overlap with people with cerebral amyloid angiopathy, and there's definitely a subset that have both. Okay. And in this collage, I just wanted to go through this quickly. These are MRI findings in all the other types of dementia, right? And I'll just go through this quickly. This is a patient with frontotemporal dementia who has atrophy in her right frontal lobe. This is a patient with progressive non-fluent aphasia who has atrophy in the left frontal lobe. This is someone with semantic dementia with left temporal lobe atrophy. This is someone with CADASIL, which is a genetic disorder that causes strokes at high levels in the brain, who has dementia and who has lots of strokes in the brain. This is somebody who has Creutzfeldt-Jakob disease, a prion disease. Mad cow disease is one of those prion diseases. And there's a signature of this on these MRI scans as well. And this was a patient of mine with autoimmune encephalitis who has edema in the frontal lobes and subcortical areas. And so we look for all of these things in these MRI scans, and it helps us to distinguish Alzheimer's disease from other conditions. Okay, so now we're moving on to something a little bit more recent. So there is now, I would call the gold standard for Alzheimer's disease biomarkers in this current day and age. It's called amyloid positron emission tomography, or PET scanning. And I'm sure many of you have heard of PET scanning, probably in the setting of cancer patients, probably in the setting of looking for metastases throughout the bodies of cancer patients. You know, PET scans are not exclusively used in cancer patients. They are a way to molecularly label different biological processes in the body, okay? And in the form of cancer patients, we're usually talking about metabolism, because cancer is this highly metabolic disease. We're looking at areas where the metabolism is very high. In this case, you can use PET scans to look at where the amyloid is in somebody's brain. And how's that done? Well, you have these radioactive tracers. So you have basically a chemical compound. The first one of this type was something called Pittsburgh Compound B, developed in the, I think about 20 to 30 years ago at this point, which you can link to a radioactive tracer. Usually it's fluoride 18, right? And inject this by IV into someone's body, and it flows around through the body. And this molecule will stick to amyloid, okay? Not forever, just for a certain amount of time. It'll stick to amyloid in someone's brain. And then within hours, it'll let go and then just be excreted from the body, through the urine, okay? And so if you can time it well, then you can basically take a scanner and scan somebody's brain during that time when the tracer should be binding to the amyloid, and you can see how much amyloid is in somebody's brain, right? And that's what you see here on the left side of the screen. You'll see on the right, there's a low level of signal in the subcortical, in the center of the brain, in these white matter areas, okay? And even lower level in the cortex, or the edge, or the outside of the brain here. Whereas in someone who has an amyloid PET positive scan, you see these high levels of intensity, PET scan intensity in different parts of the cortex, specifically, throughout the brain. Okay, and so it usually is a pretty easy thing to see if you have access to this test. So as I said, amyloid PET scan is the current gold standard in living patients. There are 3 FDA-approved PET tracers that are out there. I can't pronounce these names, so I'm just going to leave it up there for you to see. Okay. And how good are they? Well, they've been compared to autopsy studies. And in different autopsy studies, they are 88 to 98% sensitive and 80 to 95% specific for detecting moderate to frequent amyloid plaques. So this, again, is the current gold standard, but I am sorry to say that it is currently unavailable in the state of Hawaii. Okay, I think there is urgency to develop this service. I think in multiple healthcare systems in our state. I think Queens is the leader, I think, at this point, and they are preparing to offer flutamidamol, and I think the target rollout date is sometime in mid-2025. Okay, and so I look forward to the opportunity to use this test, and I think it's going to add a lot to what we can offer our patients. Okay. Okay. Now let's move on to blood and CSF, or cerebral spinal fluid testing in these evaluations. As Dr. Chung said earlier, when we evaluate patients for dementia, we'll do screening blood tests to look for reversible causes of cognitive dysfunction. We look for electrolyte disorders, people who have hyponatremia. We look for kidney disease. We look for liver disease. All of these conditions, when found at a severe level, they can affect the thinking of somebody who walks into your clinic. Vitamin B12 deficiency, I find at remarkably high levels in our state. Like and honestly, the typical person usually has a diet that includes white rice and pickles and pretty much nothing else, right? Thyroid disease is obviously very common, and unfortunately in our state, I think syphilis is a bigger problem than I think anybody would like to think it is, actually. Okay. There are other complicating factors that warrant more extensive testing that Dr. Chung has gone over, right? And probably the biggest one in my mind is rapid progression. And what do we mean by rapid progression? Well, we mean somebody who's like totally normal one day and 6 to 12 months later is completely dependent. And that is rapid progression of dementia, right? And so there are tests these days for Creutzfeldt-Jakob disease, the prion disease, this RT-QoL-C test. There are panels of antibody tests for autoimmune encephalopathy, ENS2 and ENC2, and as well as the neoencephalitis panel offered by this company. And so we will selectively offer these tests to people when we have a clinical suspicion of these more rare, unusual conditions. Genetic testing is another thought, right? And as we said, there are genetic causes of Alzheimer's disease. Most of them are rare, right? The early onset Alzheimer's conditions accounts for approximately 5% of cases. And so, you know, I tend not to order these tests mostly because I don't think it really helps with the diagnosis. Right? I mean, someone either has Alzheimer's disease when you evaluate them or they don't. The genetic test doesn't really help you unless you know that their family has Alzheimer's disease in the previous generation. But it does help in order to help the patient, obviously, and counseling of future generations in those families if it's highly likely to be genetic. And so this is what a cerebral spinal fluid analysis looks like. This is what we call a lumbar puncture. Sometimes we do it lying down. Sometimes we do it sitting up. Sitting up is very much easier in my experience. This is what a spinal needle looks like. It looks really big on the screen, but it's about this big usually. Okay, this big. And I would say this is currently our local standard for Alzheimer's disease diagnosis in terms of a biomarker. Okay, so what do we look at in these tests? Where we're looking for A-beta 42, which is a subtype of A-beta, levels to decrease in the spinal fluid, and the levels in the spinal fluid decrease because they're being deposited in the brain. Okay. We also look for phosphorylated and total tau protein. So these are the components of the neurofibrillary tangles. And I would say these are markers in some ways of damage. You know, the more injury that's happened to the brain, so later stage of the disease, The more injury that's happened to the brain, the more you'll see these levels rise, okay? So spinal fluid analysis has been studied now for a good 10 to 15 years. The studies show it's 85 to 95% sensitive and 84% specific compared to amyloid PET scans, which again, I think are the gold standard at this point. And I'd say functionally, to a neurologist, this is they're pretty much used interchangeably, okay? As you might imagine, because of this, there are many drawbacks. I can tell you for a fact, patients do not like lumbar punctures, okay? They don't like them. They don't want to do them. Even though I can say it is typically quite a benign test. It is definitely more complicated than drawing blood, but it typically is a lot. 90% of my patients who get a spinal tap afterwards, they're like, "Oh, that was it? Oh my God, what was I afraid of?" Right? And so, from our perspectives as clinicians, there are other drawbacks. The testing takes 2 or 3 weeks to return from mainland laboratories, and then just a logistical thing. Beta amyloid, apparently, it's kind of interesting, sticks to polystyrene, but doesn't stick to polypropylene. And so you have to use special tubes that are not usually used to handle these samples. And if you don't use the special tubes, then you're going to have false positives, right? Which is not good. Okay. I think this is the latest, I think, in this area of biomarkers, and we'll go through this, try to go through this thoroughly. I think this is what people have been waiting for. And there's a new blood test that's here now called plasma, so it's from blood, p-tau 217. So what does that mean? P-tau stands for phosphorylated tau, so it's that neurofibrillary tangle protein, okay? And it's phosphorylated on a particular residue, right? Tau protein has X number of amino acids, and this one is phosphorylated on amino acid number 217, okay? And this has been shown in recent research, just in the last, I would say, 2 or 3 years. The plasma levels correlate with amyloid plaque and tau tangle density. They increase to between 250 to 600% in patients with Alzheimer's disease, but not other forms of dementia. The test is done by mass spectrometry, which I am not a chemist, okay, but my understanding is they stick this thing in a machine and it burns it up into little component kind of molecular products, and then they analyze kind of what comes out, right? And but that's the basis of the test. And so far, the positive predictive value and negative predictive value are both in the 90% range, which is remarkable, I think, for a blood test. Never been seen before in any other blood test for Alzheimer's disease. There is one company that has put out a kind of a combination test looking at p-tau 217 and a ratio of A beta 42 and 40, which are different forms of beta amyloid in the blood. They found that it improves their accuracy slightly compared to just looking at p-tau 217 by itself in their hands. And so they're offering this test now. And that test is called this Precivity 82 test. There are other forms of this p-tau 217 that are now available through Mayo Labs and LabCorp. Locally, I believe, from what I know from just practice, I believe Diagnostic Labs is now offering a p-tau 217 lab. I'm not sure what company it goes to. I have no idea what company it goes to, but I've seen it in the, on our order sets. Okay. What I want to emphasize here first is that none of these tests, by my knowledge, and maybe there's a new thing about this, but none of these tests are yet FDA approved. Okay. So the Food and Drug Administration typically will approve, highly reliable, highly useful tests for kind of mass consumption, and that has not happened yet, to my knowledge, right? I would guess that there's a good chance, but again, I am not an expert in that, and I wouldn't want to be quoted on that. Okay, so that's the latest on biomarkers. Let's move on now to treatments. So here's the list of all of the FDA-approved treatments for Alzheimer's disease. We have the acetylcholinesterase inhibitors, donepezil, rivastigmine, galantamine. Not sure that people know this, but they all have FDA indications for different stages of Alzheimer's disease. In fact, donepezil's indicated for mild, moderate, or severe, rivastigmine only for mild to moderate, and galantamine as well, only mild to moderate. There are NMDA receptor antagonists, really one, memantine, okay, which is, as again, I don't think a lot of people know about this, but it is only indicated for moderate to severe Alzheimer's disease, not mild. I think it's used a lot for mild, but it's not FDA approved for mild. Then there's combination therapy. There's a pill that has donepezil and memantine mixed together. Well, I've never prescribed it. And then there's anti-amyloid monoclonal antibodies, and this is, I think, what people are probably interested in hearing about today. There are 3 that are FDA approved. Aducanumab, which is being discontinued this year. There was a lot of controversy over that. I don't know that I want to get into all those details, but this is going to be discontinued this year. And then there's lecanemab and donanemab, okay? So lecanemab was the first of these 2 new drugs. And this is the brainchild of Dr. Lars Lannfelt, a neurologist in Sweden who discovered a family that lived north of the Arctic Circle. So therefore, their mutation is called the Arctic mutation, okay? And what he found in his laboratory research of their amyloid mutations was that the amyloid sticks together more easily than normal beta amyloid, okay? And so he came up with this idea of removing that by monoclonal antibody, which led to 15 years or more of development of this drug, okay? It is now given as an IV infusion every 2 weeks for a total treatment course of 78 weeks. This is a human monoclonal antibody that binds and removes large soluble A-beta protofibrils and reduces beta amyloid plaques in the brain. And this was FDA approved initially in January of 2023 by the accelerated pathway, but then converted to the normal pathway in July of 2023. And here is the kicker, right? This is the main finding, which is, we should go through this pretty thoroughly. And this is a measurement of patients, some who got lecanemab, some who got placebo, okay? And how they did on a scale of function, right? It's called the Clinical Dementia Rating Scale Sum of Boxes. And what they found was the patients who got the lecanemab, their function declined over the 18-month treatment more slowly than the patients who got the placebo. How much more slowly? 27%, okay? They did very thorough analysis using a variety of different tests to make sure that this is true, right? Number one, they looked to see how much amyloid was removed from the brain in these patients, and 55% was removed on average by the end of the 18-month treatments. They did other evaluations in terms of other numerical scales for function, cognitive function, all these different things. And on all of their studies, there was a difference, a significant difference between patients who were treated with lecanemab and placebo over the 18-month trial. And so there's this expert panel that came together last year to publish these appropriate use recommendations, which I think are good for us to think about. And so they are recommending patients to qualify for the use of this drug if they have mild cognitive impairment or dementia. They should have an MMSE score or equivalent MoCA score in the 22 to 30 range. They should have a positive biomarker for Alzheimer's disease in Hawaii, currently probably CSF studies. They have to be within this age frame of 50 to 90. There are also BMI kind of limitations and all of these other things that are pretty common sense, I think. Okay. So our slides, I think, will be distributed to you, and you can look through these over time. There are also lots of exclusion criteria. And so these are people who may have a higher risk of side effects, or maybe a higher risk of having another form of dementia that shouldn't be treated with this drug, right? And so if you have a prior brain bleed of whatever type, that increases your risk of further brain bleeds with this drug. If you have significant cerebral vascular disease on the MRI scan, maybe you have vascular dementia, not Alzheimer's disease. If you have a significant psychiatric disorder, maybe that's what's causing your cognitive dysfunction and not Alzheimer's disease. If you have a bleeding disorder where you're on anticoagulation, that will increase your risk of a significant side effect down the road, right? And so, again, this will be distributed in the slides, and I invite you to review them thoroughly. What testing do we require before we give someone this drug? Well, we would want an MRI scan within the last 12 months, just to get a snapshot of what's happening biologically at the time of the treatment. Then we would want an amyloid biomarker, so amyloid PET scan or the spinal fluid analysis, as we've discussed. And then finally, we actually, in this case, for this treatment, we actually recommend testing for ApoE4, the ApoE4 allele, which increases people's rates of Alzheimer's disease. But in this case, it's because people who have this genetic variant have higher rates of side effects, okay? Here's a review of the adverse events from lecanemab. I'm just gonna point out a few things. A lot of people get infusion reactions, so flu-like symptoms when they get this drug infused. You can prevent those by pre-medicating patients with Benadryl or steroids. And then not many people stop the drug because of those types of problems, only 7% at most, okay? The main side effects that we are most concerned about with all of these medications actually are the amyloid-related imaging abnormalities. There's ARIA-E, which stands, I think, for edema, or swelling, and then ARIA-H, which is short for hemorrhage, right? And so patients who are treated with lecanemab have this percentage risk for ARIA-E, the swelling that you can see here in this part of the brain, versus ARIA-H, these little microhemorrhages that we talked about before, right? Interestingly, most patients who have these findings on the MRI scans, though, they don't have symptoms, right? Only less than 1% of the patients have symptoms from the ARIA-H, whereas 17% will develop more of this during their treatment course. And, a smaller difference between symptomatic and asymptomatic ARIA-E, okay? These complications are associated with ApoE4, kind of the genetic variant. As you can see here, patients who are homozygous for ApoE4, they have rates of these side effects in the 32 to 39% range. Patients who have no ApoE4 allele, they have very low risk, 5 to 12% risk. And so this is what drives our interest in testing for this in all patients who are considering treatment, okay? How do we detect and manage these patients? Well, again, most of these patients do not have symptoms. And so how are you going to find them? Well, you're going to find them by doing MRI scans, basically. And so, the current recommendations are for MRI scans 4 times during the treatment course, which is kind of amazing, right? It's a huge resource. Before infusions number 5, 7, 14, and 26. I'd say the highest priority would even be for patients who are ApoE4 carriers who have chosen to treat despite that risk, right? What is clear, however, is that ARIA-E, which is the riskiest of those side effects, typically occurs in the first 3 months of treatment. And so usually if you can get past 3 months without a problem, you're gonna be probably okay. Okay? Most cases are asymptomatic, but what happens if they are symptomatic? Well, people have seizures, people can have worsening confusion, people can have stroke-like symptoms. And anything like that that happens, if you ever see a patient on these drugs where they have new symptoms of these problems, they should be sent to the emergency room immediately for evaluation, okay? There are treatments for these symptoms. The vast majority reverse, and the treatments include intravenous steroids and anti-epileptic medications. Okay. Insurance coverage for lecanemab is growing. So Medicare has decided to cover lecanemab, but only if the patients are closely followed in a clinical registry, which means whoever's prescribing it has to punch in data into a computer system. Okay. HMSA, this is by my most recent knowledge, but again, something might have changed, they were still developing their drug coverage policy, and Dr. Toby Smith, who is their medical director for geriatrics, I believe, he is reviewing each request individually at this time. Okay, how much does this thing cost? Well, the average retail cost for lecanemab is $26,500 per year. Medicare covers typically 80%, and so you can do the math there. Plus, there's additional costs, right? All of those MRI scans, that costs money, right? All of these genetic testing, that costs money, right? So this can quickly add up, for patients who are interested. We began treatments on December 14th, 2023. These are my first 2 patients, and they are still getting treated, actually. And this one on the left, he developed atrial fibrillation after a couple months of treatment. And so we had to stop treatment. He went on anticoagulation briefly. We ended up getting him through the Watchman device pathway. He got a Watchman device placed, stopped anticoagulation, and now he has restarted treatment at this point. And the patient on the right, I swear she has never had any side effects, no infusion reactions, no ARIA, and her MMSE score improved by 3 points in the first 6 months of treatment. So that's the experience. So moving forward, what's coming down the pipeline? There's subcutaneous injections for lecanemab that are coming, okay? So what's the point of this? Well, I think this is going to open lecanemab up to more patients, right? Because you don't need to send them to an infusion center to get treated, right? The research shows that you can get similar blood concentrations with weekly subcutaneous injections There's similar amyloid removal at 6 months, similar ARIA rates to IV lecanemab. And so, as I've looked closely at the company website, they seem to be interested in rolling this out for maintenance therapy in this time frame and for initiation therapy 1 year later. Next, finally, this is the last part of the talk. Donanemab. This is the most recently FDA-approved drug. It's an IV infusion every 4 weeks. Every 4 weeks. That's obviously better than every 2 weeks, right? It's a human monoclonal antibody that binds to a pyroglutamate form of A beta that's specifically found in amyloid plaques. Why does that matter? Well, there's different properties of this treatment, and we'll try to go through this. In the trial for this drug, they did amyloid PET monitoring at 24 weeks, 52 weeks, and 72 weeks. So what does that mean? That means they wanted to see how fast the amyloid was being removed from the brain, and we'll go over those results. And what they did was, if you removed as much amyloid as you could possibly remove, then they stopped the treatment. And so some of the patients actually got only 6 months of treatment, some of them got 1 year of treatment, and some of them got 1.5 years of treatment. Okay? And again, this was FDA approved in July. And so these are the data, and this is a little bit complicated, but I'll try to go through this carefully. The one on the right, that is the equivalent study, similar study to what we saw on the lecanemab trial. And it's a similar result. The patients who are treated with donanemab, they have slower decline on the CDR Sum of Boxes scale over the treatment course. The one on the left actually shows a slightly different population, low to medium tau population. So these patients were also studied with a different type of PET scan to look for tau accumulation in the brain. And they separated these groups into low and medium tau versus high tau. And again, if you remember the pathway, tau comes after amyloid. And so in order to build up the tau, you have to be farther along in the disease, right? And so low to medium tau, that population is a milder stage, okay? These are milder patients than in, let's say, the lecanemab trial, right? And what they found was that in the milder stage, you actually have a more powerful effect on the patients, right? You can actually slow it down even more in the milder cases compared to all comers, okay? Which I think is interesting, and I think it helps us think about, how this thing really works, actually. If you can get to the patients earlier and treat earlier, you can have a better benefit, right? Donanemab removes amyloid seemingly more effectively than lecanemab. And I would say this based on this left graph. You can see that by the PET scan, after 24 weeks, you have more than 60% removal, okay? And at 1 year, you have more than 80% removal. And after 1.5 years, you're down to almost 90% on average. So those are better numbers than with lecanemab. There's a downside to that, which we'll talk about in a second, right? On the right, you'll see what percentage of the patients, okay? What percentage of the patients cleared all of the amyloid possible at 24 weeks? It's like 1/3 of patients. And they were able to stop treatment after half a year. After 52 weeks, 2/3 of patients in the trial, okay? And after 1.5 years, then you're up to almost 80%, okay? Adverse events. So this is where the downside potentially is for this treatment option, which is the ARIA-E and ARIA-H rates are higher than with lecanemab. So it more actively removes the amyloid, but the side effects are more significant as well, okay? As you can see, even the infusion reactions are not as common. They're much less common with this drug. But as you can see here with the homozygous carrier, okay, we're talking 40% ARIA-E in that population. And I think for the lecanemab trial, it's somewhere in the 30-something% range. So, summarize. Here's the amyloid pathway that we've talked about already, and let's talk about where all of these things we reviewed fits into this pathway. We talked about MRI scans allowing us to see atrophy or shrinkage of the brain, which is a representation of widespread neuronal death, right? We talked about amyloid PET scan, which allows us to see mostly, I think, the A beta plaques in a living individual. We talked about CSF analysis, which allows us to see the A beta oligomers, right? We talked about the p-tau217 test, which is a representation of the neurofibrillary tangle development. And then we talked about the new drugs which act by removing A beta or beta amyloid from the brain, right? And so here's our summary. I don't think we'll have to go through this in detail. And thank you for the opportunity to present.
Thank you, Dr. Xu and Dr. Chung, for the insightful presentation. Now we're going to move on to Q&A for about 5 to 10 minutes. I know break is happening fairly shortly. I know that there's volunteers that will be available to hand out microphones if you have a question. And so we'll open it up to questions at this time.
Hello? Oh, yeah. This is a question for Dr. Xu. I have 3 questions. Number 1 is that true that we do not really see the patient has an improvement of functionality during the treatment or infusion? I noticed it's basically to slow down the deterioration of the illness. And number 2 is after the completion of treatment, meaning after you detect all these, the amyloid can be lower, and how often do you test and do second treatment for do the infusion or maintenance treatment? And the last one is just curious, and the monoclonal antibody is a large molecule. How they cross the blood-brain barrier, and also it's like a collision therapy, and they bind all the junks, and how they move out of the CSF. Thank you.
Okay, that's a lot of questions. Okay. Okay, so I'm gonna go backwards because I'm having a hard time keeping it all straight. So, how does a monoclonal antibody get into the brain? Well, you know, we know that we can get antibodies into the brain. There's treatments, IVIG, you know, we know we can get antibodies into the brain. It's probably not at a huge level. The removal, though, I think comes through the vascular system and potentially the lymphatic system, I think. You know, I'd be happy to talk to you about this, you know, after the fact, because this is a long discussion, but the ARIA-E and probably the ARIA-H side effects, I think are a result, I think, of the removal of the amyloid through the blood vessels, right? It's kind of a side effect of that process. In fact, some would argue, again, there are patients with the microhemorrhagic cerebral amyloid angiopathy who never got monoclonal antibodies, who develop edema, okay? And those patients have endogenous antibodies frequently. And so I think that's how the antibodies go in and come out, right? Okay, the other 2 questions. Okay, yeah, that's a good question. You know, in my mind, I would say this, that, you know, the brain, your overall brain function has to do with the overall integrity of your brain structure and the brain cells and how those connections, those trillions of connections between your brain cells are working, right? And we believe that the Alzheimer's disease, you know, the amyloid is disrupting those normal processes of the brain, right? And this is a drug that can remove the amyloid almost entirely, potentially, to place the brain at less risk. But it is not a drug that can rebuild trillions of neuronal connections that may be lost over time. That's the way I would think about it, right? And so it can help, but it's definitely not a cure, and it's definitely not gonna you know, rebuild someone's brain, right? There was a third question, which I forgot. Oh, that's a great question. This is an area of uncertainty, I would say, in the field. And the question was about, you know, after the 1.5 years of treatment, what do you do? Do you stop then? Do you keep going? You know, and there's a lot of people. What?
You spend almost $100,000 on people who are 50 to 90 years old. Maybe it's time to deny treatment.
Yeah, you know, that I think that may be a reasonable position. That's not a position that I'm prepared to make for the entirety of this community or nationally, right? You know, but it's a reasonable perspective, I think. I would say among the neurologists that I've spoken to about this nationally, that some are thinking that they're going to continue treatment with lecanemab, and there are now extension studies that have shown that people continue to have more benefit over time as they extend their treatment beyond 1.5 years. Okay, that's one thing. I've talked to other neurologists, very prominent neurologists nationally, who have told me that they plan to continue to evaluate with the PET scans and to stop treatment when all the amyloid is removed. And this is why I think the option for donanemab, despite the fact that, you know, it seems like it's higher risk in terms of side effects, but potentially a higher reward in terms of you may be able to stop sooner than 1.5 years or forever, right? You know, it's a very attractive potential option, right?
I had a follow-up question to the doctor's question as well. What are your thoughts about neuroplasticity? Even though this is not a cure, could you still somehow promote neuroplasticity in the hippocampus?
If I had a drug that could promote neuroplasticity, I probably wouldn't be standing here kind of talking to you right now. I'd be sitting on a beach someplace, I think, okay? I don't know that we have a real way, other than lifestyle recommendations, to potentially promote neuroplasticity, right? And I think it's, you know, what we know about neuroplasticity is that there's a critical period early in life where people are very plastic in terms of the development of their synapses. And later in life, it's thought to be less so. It's not thought to be zero in my mind, but less active. And yeah.
Real quickly, we have time for 2 more questions.
Actually, if I could just say something, we're giving you the updates as to what's going on currently today, but this field is rapidly evolving. If you wait another year or a couple of years, there may be other treatment options or revised treatment options that we can talk to you about. I can't specifically make promises about plasticity-related therapy options, but just keep in mind that what we're talking about today is only what's available for right now. And this is a really exciting time. We actually do have disease-modifying therapy for Alzheimer's disease that we did not have before. So this is the first step of many good improvements to come. At least that's what I believe.
Couple of comments. One is that I think it's exciting. It's a new area. It's just starting. But it's interesting to comment. UK recently denied saying they'll cover for this, for their national program, thinking the cost-effective impact is not enough. It's interesting. Number two, the comment about slowing down disease, not curing, is still very important because all you have to do is slow it down a little bit at a large scale by so many people. So the cost to society will be just so much less, including to caregivers. The cost to society is really big. So if you slow it down, it's still definitely something worthwhile trying. Quick question to you two. Do you counsel them after ApoE testing because of the genetic counseling impact? Or do you just tell them this is your results?
Yes, so we have genetic counselors available at Queens,
Yeah.
and depending on the findings, their need for counseling, we can certainly offer that. The one issue, though, is that if you're just talking about numbers of people who have concerns about memory impairment, Alzheimer's disease, those that go through the ApoE testing, the number's just too great, and the genetic counseling clinic just can't accommodate everybody. But on a case-by-case basis, as they need it, we have counseling services available.
Yeah, I would say that in my practice, I try to advise patients, with the risks and benefits of these treatments very thoroughly and personally, myself, one-on-one. And I've had one patient who otherwise would have been a perfect candidate decline treatment because of ApoE4. Yes, one. Yes.
Have a question. Dr. Chang and Dr. Chu, thank you for very detailed presentations. And it was very awful statistics. What do you think about the existing online screening programs on Alzheimer? Is it useful for assessing risk or early manifestation? Or maybe for self-diagnostic or family members diagnostic on the stage of suspicions only? Online screening programs.
Oh, I see. So if I understand the question, it's about online screening that people can do on their own to assess memory function?
Yeah, self-diagnostic.
So let me just make a brief point. The validated questions that we have available to evaluate patients with these concerns, there are only so many of them. And in this day of the internet where you can access any information you want, the testing that we use in the clinic, anybody can access them on the internet. It is available. But the problem is patients who are exposed to those questions when they arrive in the clinic for their actual medical evaluation, if they were already exposed to those questions, it's going to influence the result. So what I tell my patients is, well, do what you want to stimulate your brain. Do puzzles, read books, anything that's mentally stimulating. But please avoid looking up memory test questions and practicing for the test before you arrive for your appointment, because that's cheating. And it makes my life very difficult.
Thank you.
Thank you, and I'm so sorry we had to cut question and answer short. Please, again, a big round of applause to Dr. Xu and Dr. Chang for joining us. It's